Hi, my name is Arun Mattappallil. I'm a clinical pharmacist specialist practicing at a university hospital in Newark, New Jersey. And today I'll be providing an overview on the utilization of Baricitinib, or brand name OLUMIANT, as it pertains to the utilization with COVID-19. I have no disclosures to submit. Of note, this presentation was initially given on February 2021 with this current update. If you'd like to skip to the update, please go to slides 26 through 45 to review those updates. Baricitinib is currently United States FDA approved for moderate to severe rheumatoid arthritis in patients with inadequate responses or intolerance to one or more tumor necrosis or TNF antagonists. Similar approvals were given to Baricitinib in Canada and Australia. With the European Medicines Agencies, or EMA, there are two approved indications, one for rheumatoid arthritis and another for moderate to severe atopic dermatitis. Many common inflammatory diseases, including rheumatoid arthritis and atopic dermatitis, typically occur from extracellular stimuli. Some of these stimuli include cytokines, growth factors, and hormones that bind at plasma membrane receptors that often trigger intracellular signaling events that cause gene expression within cells. Often the end product of these gene expression events are pro-inflammatory markers or events. Baricitinib specifically is known as a Janus-associated kinase inhibitor, or a JAK inhibitor. So the JAK-STAT pathway is one of the most common intracellular signaling pathways which modulates gene expression. Baricitinib specifically has activity against JAK1, JAK2, and tyrosine kinase 2 relative to JAK3. Keep in mind, there's 4 members within the JAK family. Listed here are the medically approved indication dosing strategies for Baricitinib for patients with rheumatoid arthritis and atopic dermatitis. What you'll see on the left-hand side is a general consideration for dose reduction of Baricitinib when disease activity is controlled and the patient is able to tolerate it. Of note, with regards to dosing adjustments based on specific patient characteristics, there are some variances between the FDA and the EMA approvals. With regards to renal dysfunction, what you'll notice is that the FDA specifically recommends avoiding use of Baricitinib with an eGFR of less than 60 versus the EMA recommending a dose reduction to 2 milligrams per day once the creatinine clearance is between 30 to 60. With regards to drug interactions, both the FDA and the EMA talk about the most common drug interactions associated with Baricitinib that lead to increased levels, specifically the utilization of organic anion transporter 3 or OAT3 inhibitors, specifically the most common that we see in clinical practice of probenecid and gemfibrozil. Where the FDA recommends general avoidance, the EMA recommends a dose reduction with those strong OATs mentioned before. With regards to advanced age, the FDA has no recommendations on dose reduction versus the EMA recommending a dose reduction for patients greater than 75 years old. The FDA and the EMA both have a general consensus to avoid live vaccine utilization with Baricitinib, where the EMA specifically recommends avoiding any use of live vaccines during or immediately prior to the start of Baricitinib treatment. With regards to safety within specific populations for Baricitinib use, for pregnant patients, there's a difference between the FDA and the EMA approvals, with the FDA noting limited data to suggest major risk of birth defects or miscarriage for pregnant women, versus the EMA noting a contraindication with Baricitinib use during pregnancy and a recommendation to consider utilization of effective contraception during and for at least 1 week after treatment. With regards to breastfeeding women, the FDA and the EMA have similar advisements, and for pediatrics, what the FDA and EMA both note is a lack of safety and effectiveness in the pediatric population not being established. Listed are the adverse events occurring in patients treated with Baricitinib in controlled clinical trials for rheumatoid arthritis and atopic dermatitis. Very common events which occurred in more than 1 out of every 10 patients treated with Baricitinib include upper respiratory tract infections, the increase in LDL and HDL. Common events which occurred in less than 1 out of every 10 patients, but more than 1 out of every 100 patients treated with Baricitinib include a variety of infections listed here: thrombocytosis, headache, GI discomfort, an elevation in ALT and creatine phosphokinase, and skin and subcutaneous tissue adverse events including rash and acne. Uncommon events which occurred with less than 1 out of every 1,000 patients treated with Baricitinib include a variety listed here: but of note, pulmonary embolism and deep vein thrombosis were noted. Additionally, within the package inserts for the FDA and the EMA, 2 events of malignancy were reported in patients receiving baricitinib in the clinical trials. The FDA has specific black box warnings for the most serious adverse events which occurred listed here for baricitinib, including infection, malignancy, and thrombosis. On the bottom right, what you'll notice is a checklist of lab work recommended by the FDA and EMA to collect while a patient is receiving baricitinib. Given the scale and rapid spread of SARS-CoV-2 in the beginning of 2020, there is an immediate need for medications which would treat COVID-19. SARS-CoV-2 is known to cause a hyperinflammatory response. An organization called Benevolent AI published 2 papers in The Lancet in February 2020 indicating that baricitinib could potentially reduce the body's hyperinflammatory response to the virus and potentially reduce patient mortality. This paper also reported antiviral properties with baricitinib, specifically that baricitinib also inhibits other kinases aside from JAK, and these kinases normally promote viral endocytosis or entry into cells. The clinicaltrials.gov database of privately and publicly funded clinical studies conducted around the world reported 15 trials evaluating baricitinib use in COVID-19 to the date of this recording. Listed on this slide include an assortment of groups reporting recruitment or completion of their trials. The trials listed here are either recruiting or not yet recruiting. A bulk of the remainder of this presentation will focus on the one completed trial listed on this slide, which is the Adaptive COVID-19 Treatment Trial 2, or ACT-2 clinical trial. This was an investigation done in collaboration with the manufacturer of baricitinib and the United States National Institute of Allergy and Infectious Diseases, or the USNIAID. Listed here for you is a study design overview of the ACT-2 clinical trial. Patients received either baricitinib 4 mg once daily or placebo for up to 14 days. Both treatment arms received remdesivir for less than or equal to 10 days based on the results of the ACT-1 clinical trial for COVID-19, along with the FDA emergency use authorization for remdesivir, which occurred on May 1st, 2020. The sponsor of this trial was the NIAID through the US government, and this trial occurred at 67 sites in 8 countries. The recruitment dates occurred from May 8th, 2020 to July 1st, 2020. Keep in mind, patients were randomized 1-to-1, and both the investigator and the participants were blinded for baricitinib. Stratification occurred by site and by disease severity. The definition of severe COVID-19 included patients that required invasive or non-invasive ventilation, along with the use of high-flow supplemental oxygen devices. The sample size and primary analysis were looking to achieve 85% power to detect a recovery rate ratio of 1.25. So enrollment needed to ensure that at least 723 patients recovered from COVID-19. Listed here is a selected summary of the inclusion criteria for eligibility to ACT-2. The remainder of the inclusion criteria are located in the supplementary appendix of the published report. Briefly, if individuals were admitted to a study site facility with signs and symptoms suggestive of COVID-19 were greater than or equal to 18 years of age at the time of enrollment, had lab-confirmed SARS-CoV-2 infection, and COVID-19-related illness of any duration with at least one of the following, including radiographic infiltrates by imaging or poor oxygenation indicative of SpO2 less than or equal to 94% on room air, or requiring any sort of supplemental oxygen or mechanical ventilation or ECMO were eligible for this trial. In addition, an 8-category ordinal scale was utilized in ACT-2 at the time of patient enrollment and to aid in determining patient outcomes. Categories 1, 2, 3 focus on recovered individuals, so they vary from not being hospitalized at all to being hospitalized but not requiring supplemental O2. Categories 4, 5, 6, and 7 focus on at the time of enrollment and look at hospitalized individuals not requiring supplemental oxygen but requiring a medical admission, to individuals that require supplemental oxygen, to individuals that require non-invasive ventilation or high flow oxygenation, to individuals that require mechanical ventilation or ECMO. Listed here is a selected summary of the exclusion criteria for ACT-2, broken down to 4 major categories, including lab work related, patient related, medication exposure related, or infection related. Digging down a bit more, the concerns were primarily related to adverse events associated with remdesivir or baricitinib that could be exacerbated with these conditions, contraindications for use of remdesivir or baricitinib, patients with medical conditions with a high risk of developing an active infection, patients receiving medications with a high risk of developing an active infection, patients receiving medications that also cause profound immunomodulation. In the last instance, this would make it difficult to determine whether or not baricitinib as part of a treatment arm had any additional benefit for patients with COVID-19. Act 2's primary outcome was to determine the time to recovery for patients with COVID-19 in either treatment arm. Day of recovery is defined as the first day on which the subject satisfies one of the first three categories from the prior mentioned ordinal scale. As a reminder to the audience, Category 1 within the ordinal scale were individuals not hospitalized with no limitations of activity. Category 2 was defined as not hospitalized but with limitations of activity and or requiring home oxygen. Category 3 were individuals hospitalized, not requiring supplemental oxygen, and no longer requiring ongoing medical care. The key secondary outcome was focused on clinical status at day 15 based on the prior mentioned 8-category ordinal scale. A selected summary of additional secondary outcomes is listed here, with the remainder located in the supplementary appendix of the published report. Additionally, safety outcomes were focused on adverse events occurring in treatment arms. A focus was noted on grade 3 and grade 4 adverse events and serious adverse events that occurred through day 29. Grade 3 adverse events being severe adverse events, grade 4 being life-threatening or disabling adverse events. This grading is based on the Division of Acquired Immunodeficiency Syndrome, or DAIDS, table for grading the severity of adult and pediatric adverse events, last published in July 2017. A selected summary review of the Act 2 enrolled patient demographics between treatment arms is provided in the next 2 slides. The remainder of reported patient characteristics is located in the supplementary appendix of the published report. Briefly, a majority of the patient population were white and or Hispanic, Latino, Latinx, male, less than 65 years of age, and located in North America. When focusing on the severity of illness at enrollment, approximately 2/3 of the enrolled population in both treatment arms are presented with moderate disease defined as SpO2 greater than 94% and respiratory rate less than 24 breaths per minute without supplemental oxygen. The remaining 1/3 of the enrolled population in both treatment arms had presented with severe disease defined as requiring mechanical ventilation or requiring oxygen, or an SpO2 less than equal to 94% room air, or tachypnea defined as a respiratory rate greater than equal to 24 breaths per minute. Of note, most participants had 2 or more coexisting medical conditions. The majority of patients randomized were under a designation of ordinal categories 5 through 7, while the actual disease severity at baseline was designated as moderate disease for the study majority. This reflects a difference in actual disease severity at baseline versus at the time of randomization, which may be indicative of individuals having worsening presentations of COVID-19 by the time of study enrollment. Listed here is an overall review of all study participants between treatment arms, with a focus on the primary and key secondary outcomes. Patients who received combination treatment with baricitinib plus remdesivir recovered a median of 1 day faster than patients who received remdesivir and placebo. The median time to recovery was 7 days versus 8 days, with a rate ratio of recovery at 1.16 at a 95% confidence interval established between 1.01 to 1.32, with the p-value noted at 0.03. The key secondary outcome of clinical status at day 15 by the 8-category ordinal scale found that within the overall population, patients given baricitinib had a 30% higher odds of improvement versus placebo. The cumulative recovery estimates are shown in the overall population from day 1 through day 29 on the left-hand side of this slide. As a reminder, Act 2 was not powered to detect difference in mortality between the treatment arms. Listed here is a review of study participants between treatment arms with an ordinal scale designation of 4 at baseline, with the focus of the primary and key secondary outcomes. These are individuals that were hospitalized, not requiring supplemental oxygen, but requiring ongoing medical care. Patients who received combination treatment with baricitinib plus remdesivir recovered a median of 1 day faster than patients who received remdesivir and placebo, with the median time to recovery at 5 days versus 4 days, and a rate ratio for recovery at 0.88, with a 95% confidence interval established at 0.63 to 1.23. The key secondary outcomes of clinical status at day 15 by the 8-category ordinal scale found that within this group of the study population, patients given baricitinib had 40% lower odds for improvement versus the placebo arm. The cumulative recovery estimates are shown in the overall population from day 1 to day 29 on the left-hand side of this slide. Listed here is a review of study participants between treatment arms with an ordinal scale designation of 5 at baseline, with a focus of the primary and key secondary outcomes. These are individuals that were hospitalized requiring supplemental oxygen. Patients who received combination treatment with baricitinib plus remdesivir recovered a median of 1 day faster than patients who received remdesivir and placebo, median time to recovery at 5 days versus 6 days, a rate ratio for recovery at 1.17 with a 95% confidence interval established at 0.98 to 1.39. The key secondary outcome of clinical status at day 15 by the 8-category ordinal scale found that within this group of the study population, patients given baricitinib had 20% higher odds of improvement versus placebo. The cumulative recovery estimates are shown in this population from day 1 to day 29 on the left-hand side of this slide. Listed here is a review of study participants between treatment arms with an ordinal scale designation of 6 at baseline, with a focus of the primary and key secondary outcomes. These are individuals that were hospitalized on non-invasive ventilation or high-flow oxygen devices. Patients who received combination treatment with baricitinib plus remdesivir recovered a median of 8 days faster than patients who received remdesivir and placebo, median time to recovery at 10 days versus 18 days, a rate ratio of recovery at 1.15 with a 95% confidence interval established at 1.10 to 2.08. Note the stark difference in median time to recovery of patients in ordinal category 6 versus ordinal category 4 through 5. It's a comparison of 8 days faster versus 1 day faster. The key secondary outcome of clinical status at day 15 by the 8-category ordinal scale found that within this group of the study population, patients given baricitinib had a 120% higher odds of improvement versus placebo. The cumulative recovery estimates are shown in this population from day 1 to day 29 on the left-hand side of this slide. Listed here is a review of study participants between treatment arms with an ordinal scale designation of 7 at baseline, with a focus of the primary and key secondary outcomes. These are individuals that were hospitalized on mechanical ventilation or ECMO. The median time to recovery was not possible to estimate in this group. However, the rate ratio for recovery was estimated at 1.08 with a 95% confidence interval established at 0.59 to 1.97. The key secondary outcome of clinical status at day 15 by the 8-category ordinal scale found that within this group of the study population, patients given baricitinib had a 70% higher odds of improvement versus placebo. The cumulative recovery estimates are shown in this population from day 1 to day 29 on the left-hand side of this slide. A focused highlight of the times to recovery according to subgroups, specifically the rate ratio for recovery, include differences in the following subgroups. Within the age grouping, where a rate ratio for recovery was better in patients given baricitinib between the ages of 40 to less than 65. Within the sex grouping, where a rate ratio for recovery was better in male patients given baricitinib, and within the ethnic grouping, where a rate ratio for recovery was better in patients given baricitinib who were not identified as Hispanic, Latino, or Latinx. As mentioned in previous slides, the rate ratio for recovery was better when the ordinal scale baseline was a category 6 versus 4, 5, and 7 in patients given baricitinib. A selected summary of secondary safety outcomes is listed here, with the remainder located in the supplementary appendix of the published report. Similar adverse events occurred between treatment groups. The most common grade 3 or 4 events included hyperglycemia, anemia, lymphopenia, and acute kidney injury. The serious adverse events noted within the FDA and EMA product information reports including secondary infections and thrombosis, were not of significantly higher incidence between treatment groups. Here are some take-home points of the Act 2 trial. The purpose of this investigation was to evaluate whether baricitinib would improve outcomes among patients hospitalized for COVID-19. This was a double-blinded, randomized, placebo-controlled trial with 2 treatment arms. Either patients received remdesivir plus placebo or remdesivir plus baricitinib. The study took place primarily in the United States with a patient demographic that was majority male and white. The results focused on a primary outcome of the time to recovery between treatment arms. Within the overall study population, recovery occurred 1 day faster when patients were given baricitinib. In patients on non-invasive ventilation or high-flow oxygen devices, recovery occurred 8 days faster when patients were given baricitinib. The key secondary outcome of clinical status at day 15 by the 8-category ordinal scale found that within the overall population, patients given baricitinib had a 30% higher odds of improvement versus placebo. Adverse events were similar between groups, with the most common grade 3 or grade 4 events listed here. Limitations included the study design not being created to detect a difference in mortality, and limitations on the study population representation with racial, ethnic, gender, and age groups. The authors concluded baricitinib plus remdesivir improved time to recovery at day 15 and noted upon further stratification that patients designated as receiving high-flow oxygen or non-invasive ventilation had the greatest difference in time to recovery. Based on the results of the Act 2 trial, the study sponsor placed an emergency use authorization or EUA application for baricitinib for the consideration in the management of COVID-19. On November 19, 2020, the FDA allowed for emergency use authorization of baricitinib by healthcare providers for the treatment of suspected or confirmed COVID-19 in hospitalized adults or pediatric patients greater than 2 years of age requiring supplemental oxygen, invasive mechanical ventilation, or ECMO. To keep in mind, the Act 2 clinical trial did not evaluate pediatric patients. However, the study sponsors submitted pharmacokinetic data, which the FDA found to be reasonable based on prior PK trials for baricitinib use in juvenile rheumatoid arthritis and atopic dermatitis, along with a few other indications. Something to keep in mind is that the emergency use authorization recommended a total duration of 14 days of baricitinib or until hospital discharge, whichever one comes first. To be clear, the optimal duration of treatment is unknown, and this was mentioned in the emergency use authorization as well, too. Additional information can be found within the EUAs given by the FDA.
The remainder of this presentation will review an update of a preprint publication with regards to the utilization of baricitinib in the management of COVID-19. The trial is dubbed as the Efficacy and Safety of Baricitinib in the Patients with COVID-19, results of a randomized double-blinded placebo-controlled parallel group. This group is also known as COV-BARRIER. Please keep in mind this study is still pending full publication release. Listed here is an overview of the COV-BARRIER clinical trial group, looking at the utilization of baricitinib versus placebo for up to 14 days. Both treatment arms within this clinical trial received standard of care. That included either corticosteroids, including dexamethasone, antibiotics, antivirals, including remdesivir, antifungals, and antimalarials. The study was multi-site and multi-center, which occurred from June 2020 to June 2021. Study participants were randomized 1-to-1 and double-blinded for the receipt of baricitinib by both the study group investigators and the participants. Stratification occurred by site by disease severity, and the definition of severe COVID-19 included invasive or non-invasive mechanical ventilation or the utilization of high-flow supplemental oxygen. Listed here is a selected summary of the inclusion criteria for COV-BARRIER. The remainder of the inclusion criteria can be found within the supplementary appendix of the preprint publication. Briefly, individuals that were hospitalized with COVID-19 that were greater than equals 18 years of age and had lab-confirmed SARS-CoV-2 were included in this trial. Originally, the trial required to have evidence of pneumonia or to have evidence of active COVID-19 infection with the criteria they're listed for you. However, subsequently, an amendment was made which stipulated the requirement of supplemental O2 at the time of study entry and at randomization. In addition, individuals were required to have markers or indicators indicating risk of COVID-19 progression. These typically include inflammatory markers that we commonly utilize listed there for you. The ordinal scale, as you can see, is similar to the ordinal scale that we utilize within Act 2. Most clinical trial participants fell within ordinal categories 4 through 6. Listed here is a selected summary of the exclusion criteria broken down to 4 primary categories for the COVID-BARRIER clinical trial. When looking further into these categories, they were primarily related to lab work related, patient related, medication exposure related, and infection related. On further examination, the concerns were as follows. Primarily related to adverse events associated with baricitinib as standard of care, which can be exacerbated with these medical conditions, contraindications for the use of baricitinib as standard of care, medical conditions which had an increased risk for developing infection, medications which increase the risk of developing infection, medications which had strong immunomodulation, which could prevent determining whether or not baricitinib had a significant benefit with regards to COVID-19 management, and then active infections, which could increase the risk of the patient having an adverse event when taken with an investigational agent such as baricitinib. When reviewing a broad summary of the study population, there were a total of 1,525 participants within both treatment arms, broken down further into various population groups for the purposes of statistical analysis for both the primary and secondary outcome listed here for you. The primary outcome of the COVID-BARRIER clinical trial is to look at the progression of patients from ordinal categories 6 through 8 by day 28 after completion of a 14-day course of treatment, whether it was within the baricitinib plus standard of care treatment arm or the placebo plus standard of care treatment arm. Broken down further into 2 populations. Population 1 included all patients within the intent-to-treat model, and the population 2 were patients that required oxygenation supplementation and were not receiving systemic corticosteroids for COVID-19. When looking at the key secondary outcomes as well too, they primarily focused on patient recovery, morbidity, and mortality. Listed here in detail are those key secondary outcomes. Just as a reminder to the audience, ordinal categories 6 through 8 included individuals that required non-invasive mechanical ventilation or high flow oxygenation, mechanical ventilation or ECMO. A selected summary review of the COVID-BARRIER demographic and clinical characteristics of the patients at baseline is listed here for you. The remainder is located within the supplementary appendix of the preprint publication. Briefly broken down, when we look at the patient population between treatment arms, most patients were male, white, less than 65 years of age, and were primarily located outside of North America. Most patients enrolled into the COVID-BARRIER clinical trial treatment arms required supplemental oxygenation at baseline. In addition, a majority of study participants received systemic corticosteroids in congruity with standard of care during the study duration. When reviewing the primary outcome of progression of patients to ordinal categories 6 through 8 by day 28, within population 1, which included all patients in the intent-to-treat model, and patient population 2, which included patients that required oxygen supplementation and were not receiving systemic corticosteroids for COVID-19, there was no significant difference between baricitinib plus standard of care or placebo noted. On the right-hand side, what you can also see is the distribution of the study participants with each ordinal scale score over time. When reviewing key secondary outcomes as pertaining to patient recovery, there was no significant difference noted between treatment arms. Again, when reviewing key secondary outcomes as pertaining to patient recovery, there was no significant difference noted between treatment arms. All-cause mortality in COVID-BARRIER by day 28 was 8.1% of patients in the baricitinib treatment arm and 13.1% in the placebo treatment arm, resulting in a 38.2% reduction in mortality with the utilization of baricitinib.
Within COVID-BARRIER, across all the pre-specified baseline disease severity subgroups, mortality estimates were found to be numerically lower among those who received baricitinib than those who received placebo. Of note, the difference in mortality was most pronounced in the subgroup of 370 patients who received high-flow oxygen or were on non-invasive mechanical ventilation at baseline. These were categorized as ordinal scale number 6 patients. While the majority of study participants received corticosteroids, baricitinib was found to have a difference in all-cause mortality with or without corticosteroid use in the general population. As you can see here, the occurrence of adverse events, serious infection, and venothrombotic events were comparable in the baricitinib and placebo arms. To provide some take-home points for COVID-BARRIER, the purpose of this clinical trial was to evaluate whether baricitinib would improve outcomes among patients hospitalized for COVID-19. This was a double-blinded randomized placebo-controlled trial that included placebo plus standard of care or baricitinib plus standard of care for a duration of 14 days. This study occurred primarily outside the United States, and the population was primarily male and white. When focusing on the primary outcome, which included progression to ordinal category 6 through 8 by day 28 after a 14-day course within either treatment arm, there was no significant difference noted with baricitinib versus control. With regards to the key secondary outcome of all-cause mortality at 28 days after a 14-day course with either treatment arm, there was a significant reduction in mortality associated with baricitinib at 38.2%. The difference in mortality was 13.1% in the control arm versus 8.1% in baricitinib treatment arm. Adverse events were similar between treatment groups, and these included serious adverse events, infection-related adverse events, venothrombotic adverse events, and general adverse events as well too. Limitations to this trial include that the current information available is through a preprint, and there's a limited supplementary appendix data. So eventually this trial will require a full peer review and publication. The primary outcome also did not reach statistical significance, and there were differences and limitations noted with racial, ethnic, gender, and age-related groups. That being said, with regards to utilization of baricitinib and standard of care, there may be a reduction in mortality, which was noted within this clinical trial. And then when further stratified, patients designated as ordinal scale 6, individuals that required high-flow oxygen or non-invasive mechanical ventilation, there was reported to be a very strong benefit. Listed here are treatment recommendations for the use of baricitinib from selected U.S. medical organizations for the management of COVID-19. As a reminder, evidence to date suggests a mortality benefit when corticosteroids are utilized in the management of COVID-19 in patients that require supplemental oxygen. In addition, with certain clinical manifestations of COVID-19, tocilizumab is also known to have a mortality benefit. More information on these two therapeutics can be found in the COVID-19 therapeutics review provided by SIDP. When reviewing the Infectious Disease Society of America recommendations for the utilization of baricitinib, what they specifically focus on are hospitalized patients with severe COVID-19 that have elevated inflammatory markers but are not on invasive mechanical ventilation. These are individuals that would fall within the ordinal category designation of 5 to 6. They suggest specifically that baricitinib rather than no baricitinib may be beneficial for these individuals. They also stipulate that in hospitalized patients with severe COVID-19 where a corticosteroid cannot be used for medical contraindication, they suggest the utilization of baricitinib with remdesivir rather than remdesivir alone. This recommendation has a lower certainty of evidence, however. When reviewing the NIH recommendations, the differentiation with the Infectious Disease Society of America or IDSA recommendations primarily look at individuals that fall within the ordinal scale category designation of 6 versus ordinal scale designation category of 5. When we look at individuals that require supplementation of oxygenation but don't go beyond ordinal scale category 5, the NIH specifically mentions that there's insufficient evidence to suggest that baricitinib would be beneficial for these patients. However, it makes the caveat that some panel members, in their opinion, would consider utilization of addition of baricitinib in patients that
rapidly require increasing oxygen demands or have increasing inflammatory markers, but that are not yet on high flow or non-invasive mechanical ventilation. For individuals that fall within ordinal scale category 6, these are individuals that require oxygenation through a high flow device or non-invasive mechanical ventilation, but not yet on invasive mechanical ventilation or ECMO. For recently hospitalized patients or individuals that have been within a 3-day hospital admission that have increasing oxygen requirements or require high flow or non-invasive mechanical ventilation and have elevated inflammatory markers, they really suggest the benefit of Baricitinib as an addition to standard of care specifically. There are also additional scenarios provided by both treatment guidelines, but they are limited to the context of clinical trials. Listed here are recommendations from global medical organizations with regards to the management of COVID-19 and the utilization of Baricitinib. Specifically with the Australian guidelines, they recommend the utilization of Baricitinib for hospitalized patients with COVID-19 that primarily fall within ordinal scale categories 5 and 6, similar to the Infectious Society of America and the National Institute of Health within the United States. To provide a summary of the content discussed earlier, in the Act 2 clinical trial, Baricitinib plus remdesivir was found to reduce recovery time and accelerate improvement in the clinical status of hospitalized patients with COVID-19, notably those that required high-flow oxygen or non-invasive mechanical ventilation. These are individuals that are typically designated under ordinal scale category 6. In the COVID-BARRIER clinical trial, Baricitinib plus standard of care was found to reduce 28-day mortality in patients hospitalized with COVID-19 that required supplemental oxygen, high-flow oxygen, or non-invasive mechanical ventilation. These are individuals that fall within ordinal scale categories 5 and 6. The FDA issued an EUA after Act 2 for the utilization of Baricitinib in the management of COVID-19 for hospitalized adults and pediatrics greater than 2 years of age that required supplemental oxygen of various degrees or required invasive mechanical ventilation or ECMO. The EUA also has some additional guidance with specific clinical context. More can be read within the EUA. The Infectious Disease Society of America, the NIH, and some other global medical organizations suggest similar conditional recommendations for the utilization of Baricitinib in adult hospitalized patients for the management of COVID-19 that require high-flow oxygen and/or non-invasive mechanical ventilation. They also stipulate other applications and indications that are suggested to be utilized within the context and conditions of a clinical trial.
Thank you for listening to this therapeutics review. If you have any questions, feel free to contact me. My contact information is listed on the slide.